Hello, this is Dr. Philip May. I'll be speaking with you today about the basic introduction to evaluation and treatment of destructive behaviors in persons with developmental disabilities. There are roughly 160,000 persons with developmental disabilities in the United States today who demonstrate destructive behaviors. And by destructive behaviors, I'm referring to behavior that results in injury to the person, to other people, or to property. The annual cost of care for these individuals exceeds $3 billion. The causes of destructive behavior include environmental factors such as staff, peers, residents, and programs. In other words, the way the person interacts, who he interacts with, where he interacts can all have an impact on behavior. Personality factors need to be considered. Some people simply need a little more peace and quiet. Some people need to be alone. They need solitude. Other people get anxious if they're not around people. So there are certain characteristics of individuals that need to be considered. Is he a loner? Is he gregarious? How does he tolerate a lot of noise? Commotion, this type of things. An anxious person, not necessarily a psychiatric problem, but does he tend towards anxiety? Does he kind of overreact a little bit? Is that just his personality? Another thing to consider, medical illnesses. For example, sinusitis, gastroesophageal reflux, or arthritis. Is there some kind of pain going on? And then some types of seizures are associated with behavior changes. Next, always consider drug toxicity. Some people will get hyperactive from antidepressants. The SSRIs are known to be associated with hyperactivity. There's a so-called serotonin syndrome that can result. Lamictal is another one, a seizure drug. So always ask the question, are the medications that the person is on, are they playing a role in the maladaptive behavior? And then there may be an actual psychiatric disorder, such as bipolar, psychosis, etc. Also consider the specific neurodevelopmental diagnosis, because there are a lot of behavioral phenotypes. For example, Smith-Magenis. The people with Smith-Magenis syndrome have an insatiable need for attention, and if they don't get it, they'll act out. People with Angelman syndrome can be very mischievous and like to create a disruption. They seem to be amused by that. People with phenylketonuria can be very hyperactive. The chromosome 22q11.2 deletion syndrome is associated with schizophrenia. Of course, Prader-Willi syndrome is associated with an insatiable need for food, and they'll do anything to get it. So these are examples of behavioral problems that result from the specific syndrome that they have. So it's very important to know that. And then lastly, there are some specific brain abnormalities that can be noted on MRI, which are associated with impulsivity. There are many studies which have shown ventricular dilatation associated with schizophrenia. And it's kind of a non-specific finding, but nonetheless, it does seem to ventricular enlargement, which may reflect damage to the limbic system, the caudate and controlling areas that control the amygdala, may be damaged, and that may explain the impulsivity that a person has. So sometimes just an evaluation of the MRI may indicate, some loss of or damage to the impulse controlling areas of the brain. Next, we get into treatments of behavior. Of course, the treatment depends upon the diagnosis. What is causing the behavior. If there's something in the environment, for example, there may be certain other residents or clients of a group home or developmental center. If there's congregate living, that may be upsetting to the individual. Maybe difficulty living, with other people. There may be a lot of noise or not enough noise. There may be certain staff that the person is used to, and maybe that staff person is no longer available. There may be problems with people or the environment, either in an institution or community. So it's always important to consider the environment before a medication is considered. Also, behavioral modification programs can be very effective in selected cases, so it's important for a psychologist to do a behavioral analysis and indicate whether there might be some psychological approaches to the problem. And then the general medical doctor needs to rule out medical illnesses that may be causing pain or discomfort. If there's an evaluation of the drugs that the person is on, if some are felt to be unnecessary, it might be good to try to taper some of those drugs that might possibly be contributing to the behavior. And then it's also important to consider the addition of drugs as treatment, of course, if that's felt to be appropriate. Another treatment approach is physical exercise, getting the person outside for daily walks, treadmills if they're cooperative for something like that. And lastly, there's strategies based on the underlying neurodevelopmental disorder. For example, the Smith-Magenis example, the people who have a strong need for attention, perhaps trying to give them some of that attention, understanding that they do have Smith-Magenis syndrome, may allow a little more help from the staff. And longitudinal graph analysis is always useful to monitor efficacy of any treatments, regardless of what approach you choose. And certainly if drugs are used, longitudinal graphic analysis is essential. And there's another talk on LGA in this series that I suggest you participate in. Briefly, the LGA method involves 5 steps. First, to carefully define the target behavior to be counted. Secondly, to establish the baseline frequency. Try to get at least 3 months worth of frequency data. Then you begin the treatment or intervention. Next, you establish the outcomes, and you continue to determine the frequencies and adjust the treatment based on the outcome. Here's an example of a treatment efficacy graph, which is the tool of longitudinal graphic analysis, and this shows the effect of Zyprexa on the frequency of assaults. And the frequency of assaults initially is 30 to 40 times per month, and after Zyprexa is built up to 20 milligrams, the frequency comes down to about 5 times per month. And this is a nice record to have for anyone who might be providing services to the patient in the future. The value of LGA is that it provides a longitudinal record of specific problematic target behaviors demonstrated by an individual. It provides a longitudinal record of specific interventions that have been tried, medications, behavior programs, environmental changes, which are used to alter the target behavior, and it provides evidence for efficacy or lack thereof of the various attempted interventions. So it's a very useful tool. So in conclusion, a careful and complete evaluation and treatment of problematic behavior encountered in adults with developmental disabilities can lead to a significant improvement in quality of life for the special needs patient population. Thanks for listening, and if you have any questions or comments, please send me an email to ifcd.pmay@gmail.com. Bye-bye.